So Sharon Lewin, winter, does that make this scenario different for Australia? And take us forward the next few months. Where are things going to be at?
Yeah, winter does make a difference. It's not because coronavirus necessarily gets worse in winter. We don't know the answer to that. The big concern with winter coming is that flu is still around, and so having flu together with coronavirus is not a good combination because both give respiratory illness. Plus, winter means a lot of people are indoors. In the absence of all this social distancing, you'd be indoors and mixing and in close contact with other people, and that's also not so good. We know that many viruses have seasonal variation. We don't yet know the full answer for COVID-19 and whether we will see dramatic increases in winter compared to summer months.
Your teams have been working on both treatments and vaccines. Is there anything positive for us to look forward to in the coming months? Because we're told vaccine is actually a long time off.
Yeah, we haven't spoken a lot in the public around treatments, and I think that they may play a very important role while we're waiting for a vaccine. As you just said earlier, Hamish, vaccine estimate, even though vaccines often take years to develop, we potentially could have something in 12 to 18 months. But I just want to talk about treatment for a minute. So at the moment, we have no specific treatment for the virus. People get better on their own, or they get better because they receive supportive care in hospital. But if we had a treatment, an antiviral drug that blocked replication of the virus, it could potentially do two things. It could potentially improve outcome, people don't get so sick and don't die, or also reduce transmission, because most virus transmission is related to how much virus you have on board. We know lots about that, particularly from HIV. And just recently, we've become aware of one drug in particular. It's actually an arthritis drug, a very small study, but being tested now quite widely, showing that that drug reduced the amount of virus that we could measure in someone's swab. And we actually can measure the amount of virus quite accurately, and it definitely decreased with this particular arthritis drug. So one thing that we might see in the not so distant future is a lot of understanding about drugs that block replication, and that could have implications for both clinical outcome as well as how infectious you are. So I'm a little optimistic about that. A vaccine, there's lots going on the vaccine front, lots of different trials. One vaccine now in what we call phase 1 trial, human studies looking at safety. We'll see that field accelerate quickly, but it still takes time to make sure you've got a really safe vaccine and then also have something that works.
Well, the reality depends on whether or not our hospitals get overwhelmed. So the predictions at the moment, if this hockey stick doesn't change that much, is that we'll be out of ICU beds in New South Wales. Victoria will be behind that by April 10th. And in that case, ICU physicians will be faced with some very difficult decisions. And overseas, 30 to 40% of ICU beds are filled with young people. There's one ICU, I'm told, in Melbourne at the moment where there's an 18-year-old and a 40-year-old in ICU. And so these are difficult decisions. And if you're already sick and frail, you don't necessarily put up very well with the ventilator or the heart-lung bypass, which is the ultimate treatment.
Paul Kelly, do you agree that our hospitals will reach capacity by around April 10?
No, I don't. There's a laser-like focus on looking at what we have in terms of current ICU capacity, current intensive care capacity, not necessarily intensive care unit capacity, ventilators and the like. We are really ramping up what we can do there. We've been assured by our state and territory colleagues that a doubling of capacity is a relatively simple thing. A tripling of capacity is also possible.
You have said that you expect between 20 to 60% of the population to get COVID-19. Is that still the case?
Well, that's if we didn't have these interventions and didn't flatten the curve. That's what that was referring to. So just we know the biology of the virus. We know what there's been talk about herd immunity and so forth. What we would also need to get to if a vaccine was produced, and was successfully rolled out into the population to protect all of us, and that's where the 60% comes from. So that would be an uncontrolled epidemic.
Sure, but you had said that 20% is best case scenario. Is that still the case?
We may get less, but that's 20% without the major interventions that have gone into place this week, and with potentially more to come.
Okay, so you actually think it would be lower than 20% of the population that would contract COVID-19 now?
For the time being, we need to be really clear about what the end game is here, Hamish. So we're all hoping for a vaccine in the future. If we get a vaccine that works and is effective, then we're protected and fantastic. We can really defeat this virus. If we go into lockdown, as many people are suggesting we should do now, this is not a 2 or 4 week phenomenon. It's until we get the vaccine. And if we do that, less people will be infected. But every time we take our foot off the brake, and I heard Norman talking about this very well today in relation to that paper he mentioned earlier from Imperial College. Every time we take the foot off the brake, more people will get the infection. That's just the way the infection will be. We cannot completely eradicate this infection unless we get a vaccine.
So is, in some sense, herd immunity part of our ultimate plan if there is no vaccine? Is that what you're saying?
Well, herd immunity is the alternative to total lockdown and total closure of the borders and so forth. That's one option. The vaccine is another option, and herd immunity is another option. We're not pursuing that one at the moment because that means many more people will get the infection.
But we don't have a vaccine, and we're not doing total lockdown.
We're not, but there's been many of the things that have been introduced in the last couple of days which are heading in that direction.
When you say lockdown, that might be confusing for people, of what that means. But you have a range of different social distancing measures, and we may need all of them, but we maybe could get away with some of them. So one strategy is that if you relax some of those measures, you have really souped up testing, so you just pounce on every single infection and its associated contacts. And if we had lockdown and really reduced the numbers of infections and had time to really ramp up those aggressive testing measures like what South Korea and Singapore are doing, that's another potential exit strategy, or ways to relax the severity of social distancing.
All eyes are on China at the moment, if you can believe what's coming out of China, and it's hard to know, but they're taking the foot off the brake, and only 1% of people are immune. So a lot of people are vulnerable, and it would be interesting to see what happens. The London group suggested actually pulsing the pedal, exactly as Sharon said. You take it off for a little bit, see what happens, because Paul is right. People don't realise what we're actually entering now. We have not experienced for 102 years. And this is ancient epidemiology. This is difficult stuff where we're changing the way we live for an indefinite period. It's actually... it's clearly scaring government, and when you put your foot on the brake, you can't take it off. I understand all these decisions, and then what happens with the curve, and here's the uncomfortable truth, is if you actually look at these epidemic curves, they come from the 1918 flu epidemic. It's not convincing that you actually save lives in the long term, but you actually, the hospital system, you don't kill as many doctors and nurses, to be blunt, and your hospital system stays intact, and you're able to have a much more humane society along the way. It's like planning for battle and working out at the Somme how many you're willing to lose. And it's terrible decision-making. I'm not saying terrible decision-making technically, but it's terrible to be in the position to have to make those decisions. But it's a profound change we've never experienced before in living memory.